Hello and welcome to our Virtual Rhinoplasty Meetings. My name is Dr Cameron McIntosh and I'm the President of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 17, Dr. Nazim Cerkes tells us all about how to deal with secondary rhinoplasty.
Yeah, Prof, that is amazing. And unfortunately, they can't study whilst they're there and learn more from you.
They can study. They say, Doctor, do you operate me? What I said, no, I didn't start. So.
Oh, no. Sure. Hey, well, Nazim, thank you. That was absolutely fantastic. Hey? There's lots of questions. I'm going to jump in with the questions on YouTube so long. So a question from Shahin. He says, if you don't have any septal soft cartilage, how do you bend the hard rib graft to reconstruct the dome?
Well, if the cartilage is hard, is not soft, usually from outer layer of the rib, in that case, you don't have to split the cartilage on the anterior posterior direction. You can use another way. The outer layer can be taken and can be used for bending the cartilage. A small piece, about 1 centimeter piece of the soft cartilage is sufficient to bend. As many times Dr. Toriumi used the scar tissue for the bending, instead of lateral remnants, if he doesn't have lateral remnants. The other option is to go to ear. Ear cartilage is softer, and you can reconstruct the domes with ear, more safely. But in the rib, the bending technique to me today, because I had problems in the past. I used it in the more calcified cartilage, and the patient came back to me with a fracture of the domes. Yeah. That may happen. And during the suturing also the cartilage is fractured. So it should be extremely soft to do this technique.
Okay. So following on that question, Faisal wanted to know, what do you use to cut the cartilage? Do you use that fancy chef knife, pathology blade that he uses, or what do you use to cut your ribs?
My ribs, for segmenting, I use either a dermaton blade, or many times I use the 20 gauge or 11 gauge, number 20 or number 11 blade. Simple.
Okay, great. Thank you. Boris says, great talk. He's from Colombia. He'd like to know the dice cartilage you use. Is it like a Turkish delight, or just the fascia over the dice cartilage?
No, it is like a Turkish delight. It is exactly Turkish delight as described. The Dr. Errol was putting in the surgery cell, then the Roland Daniel put it into the deep temporal fascia. I just do like the Dr. Daniel does.
There's a question from Dr. Zunga in Argentina. Would like to know, how long have the lateral crura grafts got to be?
Well, it depends on the case, but they shouldn't be too much. What I do, many cases, I fixate them to the accessory cartilage remnants in many cases. So they should be long enough to cover the gap between the lateral crura and accessory chain. If it is go if they go beyond the piriform apertura, it really bothers the patient. But on the other hand, their function for the external nasal wall is better when they are extended above the piriform apertura. But the aesthetic wise, it's not there. It's not so good.
Okay, we've got so many questions. We've got 5 minutes.
Okay.
Carlos Pedroza would like to know: have you tried for total reconstruction of the lower lateral cartilages the seagull technique with ear cartilage? He says it gives a very similar structure and form of the lower lateral cartilages.
Seagull technique, you know, is that means to bring two cartilage and suture it and then divide and turn it. I mean, seagull technique, as far as I know, because what I do, you take the conchoid cartilage and split on the middle and suture it. And
I'm going to see if I can bring Carlos in, and then he can actually explain it himself. But I don't know if he's still on the group. Yeah, here he is. Unmute, and I'm starting to ask him to start his video, but maybe he's having a cup of coffee. I've tried him. Let's just carry on with another question. So Felipe would like to know: do you place the free dice cartilage under the dorsum perichondrium or under the SMAS flap?
Usually we cannot find the dorsal perichondrium. So in the secondary cases, so it's usually not possible under the SMAS flap. But one of the important things is to stay underneath the periosteum if you can find it, to avoid thinning of the dorsal skin. It is important. But free dice cartilage I sometimes use for the very minor dorsum augmentations. But for the large augmentations, it is better to prepare a construct, because that cartilage, some people are using, you know, the free dice cartilage. They may spread around, you know, so it is not possible to control. So dice cartilage fascia grafting also needs experience. I did too many mistakes, and you know, with doing, I learned, you know, how to do better. But still, you know, there's no ideal technique for dorsum. Okay. Because in the past, I was using solid grafts, as Jack Gunter did. I was putting the key wire, and you know, I can say that maybe more than 50% of my patients I had to revise, and maybe some of them went somebody else. You know, I'm not good on that as Dr. Toriumi. He's an excellent expert, and
that's an interesting point.
And his patient population is different than ours. Yeah. You know, maybe it works much better in the you know, Asian population, but DCF for Middle Eastern is I believe it's better.
Yeah, it's an interesting comment about Jack Gunter, because I spent quite a lot of time with Spencer Cochran, and you know, he took over from Jack in the practice, and he also, the same thing of removing the solid cartilages with a K wire and replacing them with other techniques. Okay, a question in terms of smokers and secondary rhinoplasty patients.
Oh, you know, in Turkey is one of the highest smoking rate. So I operate the smokers and even tertiary, quaternary cases. I don't think in younger patients it's not a problem. I can say various carcinosis, smokers, I operated, didn't have problem. But as I told you that the cases with the short noses, we have to be careful, because when you stretch the skin downward, you may compromise the vascularity and vascular problem that happens due to the tension. That is the most important, I believe.
Okay, Prof, I'm going to have 2 more questions here. There are a whole lot more. Unfortunately, we can't get through anything. There's a question from Ali over Miss Boy. Ali would like to know, what is the best technique and material for isolated radix augmentation?
Well, that's a good question. So what I do, I didn't show it here. For the minor ones, depends on how much you're gonna resect. In some cases, I use the cephalic remnants, very, very minor augmentation, just a balance. For isolated augmentation, sometimes I use the post-auricular fascia for the minor. But for the bigger augmentation, I use morselized cartilage, but there is a big, possibility of the edge visibility. You have to bevel the edge very carefully, and also step deformity is a problem in thin skin patients. So my preference for the major radix augmentation is dice cartilage fascia graft. It gives the best thing. Also, those patients with the low radix disproportion usually has narrow radix. So on those cases, what I do, I undermine the periosteum on both sides and put the pre-dice cartilage to the sides to widen the radix area, on those cases. And the simplest way in the office to do filler.
Okay. So this brings us to the end of the lecture. Before I let you go and we say goodnight to everybody, and we meet again on Thursday for our final talk, I want to ask you this question.
Yeah.
You have some amazing, extremely experienced rhinoplasty surgeons like Dr. Turiomi on the line now. You've got registrars.
I saw him, it's an honor for me to be watched by himself.
It's great. So my question to you, if you had to say the 3 most important lessons or things or philosophies in rhinoplasty that you would like to share with us.
Oh, I think the most important first thing, the success starts with the evaluation and analysis. It is very important to do, because during the analysis, when we look at the patient, we can miss a lot of things. What I learned, I analyzed the patient on the pictures. Also, one of the important things that the palpation of the bony and cartilaginous structures. This is very important, because I saw that the face asymmetry is extremely high, particularly in our patient population. Almost 90% of the faces are asymmetric. And then when I touch the bones, I can feel there is an asymmetry. When you remove in a primary case, the dorsum, the patient comes back to you with a dorsal asymmetry, and you create an asymmetry. If you do not detect the problem, diagnose the problem beforehand, so you end up with and the second lesson is I am a surgeon is a kind of conservative. I don't want to take the risk, and I don't want to jump on the new techniques, and I'm not against the new. I'm a person that don't want to take big risks in my life. So that's why always try to be conservative in your resections rather than being aggressive. This is one of the most important issue. And the third and probably the most important thing, and to respect your patients and spend your time for your patients. My average primary rhinoplasty is about 3 hours. My average secondary like 5 hours. And when I started in 1990, I was doing a primary in 1 hour. now I spend 3 times more after doing like 5,000 rhinoplasties. So try to be, you know, to try to make your best for every patient, and also try to learn from your patients, not only, of course, from your friends, but also self-criticization is very important thing for the improvement in this surgery. And always I think that what is my mistake in this case? How I could do this case better? And yes, because the soft tissue reaction in every case is so different. You do the same type of noses in the same kind of surgery, but result is different because there are so many factors affecting the result. And that is the beauty of this surgery. I love this surgery because not my hands are not only working, my brain is working. I hate to do liposuction, you know this. I hate to do abdominoplasty. But when I do rhinoplasty, I enjoy doing that because my brain is working, and you have to be all the time concentrated and have to think the next step. You know, always you have to have a B plan in this surgery.
Yeah. That's great, eh?
This is the fun part of the surgery.
But I can see your passion for rhinoplasty. It's great.
Yeah,
so
you know,
I want to wish you good luck.
Yeah, we rhinoplasty surgeons are all patient. Otherwise, this surgery is not the surgery should be done. It's better to do Botox or, you know, liposuction, fat injection, instead of having, you know, a lot of problematic cases, particularly in our time. In the selfie time, every patient is expecting wonderful result, and Instagram is creating a lot of problem cases. You know, it's getting tougher and tougher every day.
Sure. Hey, well, Prof, thank you very much. I'd really appreciate you taking an hour and a half of your time. And for everybody around the world, thank you so much for coming in. I'd invite you guys to come back on Thursday night for our last talk of this marathon 18 lectures that we've done. So thank you very much, and enjoy your surgery on Friday again.
Okay, thank you so much. It has been a pleasure for me. Thank you for including me to this wonderful webinar series. And best regards to all friends from all over the world.
Good night, everybody.